judge overturned the mask mandate. My company and my company at this moment, if you choose to, you may remove your mask.
It's over immediately. Congratulations.
All right, well, don't necessarily keep the applause going. Dr. Anthony Fauci with us right now, the White House chief medical advisor, wasn't keen on this judge's decision, joins us right now. Dr. Fauci, very good to have you back.
Thank you, Neil. Good to be with you.
I caught your quote, sir, in which you said that this is a CDC issue. It should not have been a court issue. What did you mean by that?
Well, exactly what I said, Neil, that this is a public health issue. And the point that I was making is that you always respect a decision of a judge in a court. And in fact, that's what's happening right now because masks are coming off in transportation, planes and other forms of transportation. But the point that I was making that this is a public health decision. And I think it's a bad precedent when decisions about public health issues are made by people, be they judges or what have you, that don't have experience or expertise in public health. And I believe that this should remain a CDC decision. And the CDC has a very large number of experienced scientists and epidemiologists that make those judgments based on the dynamics of the outbreak on the ground and other considerations that they make. So I wasn't at all defying the authority of a judge because when the judge makes a decision, you abide by that decision. I was concerned about the principle of having non-public health people making public health decisions.
So what about the CDC weighing in on, a rental eviction moratorium? Now, the Supreme Court did take that up. Should the CDC have not?
That's an area, Neil, that I'm really not that familiar with, to be honest with you. I'm not trying to evade your question, but I have not been involved in looking at the details of that, and I really would be a bit hesitant to make any kind of determination on that.
Wouldn't a court be a better place, though, to deal on an issue like, a rental moratorium than a health entity, though?
Neil, I really can't say on that because it's a different situation than what you asked me about regarding the public health dangers or not of being in a closed place in transportation. I would have to really go back and take a look at that before I make any statement about evictions.
So on the mask thing in general, Doctor, people are very, very confused. It might be taken off on planes, and that's fine. But depending on where you land, let's say in the New York metropolitan area, if you're at LaGuardia or JFK, you have to put the mask back on. If you're in New Jersey at Newark Airport, you don't. Philadelphia had a mask requirement, then lifted a mask requirement. LA, I can't keep up with what's going on there. You could see why Americans are confused, right?
No, I agree with you, Neil. There is a reason for concern and confusion because there are differences of risk. When you're on a closed place in an air, first of all, I don't know what the ultimate decision that the CDC will make. You recall that the expiration of that requirement on transportation for April 18th, the CDC extended it for 15 days to May 3rd. Right. And the reason they needed that is that we are in a dynamic situation where we're in a situation where the cases had gone down dramatically over the past several weeks. But now with the BA2, we're starting to see a blip up in cases. And what the CDC is trying to determine, is that going to be reflected in an increase in hospitalizations, which is the new metric that they're using about making their determinations about requirements for masks in indoor settings as well as in places like transportation. So it's kind of a moving target. So they were asking for another 15 days to get to May 3rd. Then when the court overruled that and said that masks were coming off, it's understandable how there could be some confusion. They may have decided to pull back on the mask anyway by May 3rd. I don't know. They're using the science and what's going on on the ground. But you're right. I mean, when you have that kind of back and forth, of course that people might be confused by that.
You know, you had said, and I think I'm quoting it correctly, Doctor, no chance we will be able to eliminate the COVID virus. You would also add that there's a new COVID variant that are constantly coming soon. You didn't say constantly, I apologize. I'm wondering, though, when someone as esteemed as you says, you know, this whole COVID thing, it's not going away. That scares people. What do you think?
Well, Neil, it's the reality, because take a look at the history. I don't think it should necessarily scare people. Maybe, well, I will, and thank you for giving me the opportunity to explain it a bit. If you look at the history of infectious diseases outbreaks, namely typical respiratory-borne illnesses, we've only completely eradicated from the planet one virus that afflicts humans, and that's smallpox. That's eradication. Elimination means where you haven't eradicated it from the globe, but you've essentially eliminated it, for example, from a given country. Take the United States. So what have we done? We've done that with measles, and we've done that with polio. But there were three factors that went into our ability to do that. One, measles and polio is not a virus that changes. The measles that we had 20, 30 years ago is the same measles we have right now, number one. Number two, either infection-induced or vaccine-induced immunity is virtually lifelong. And as a matter of fact, that's what we had. And then you had a very, very effective, widely acceptable, and widely accepted vaccination campaign. That's why we were able to eliminate it. But if you look at SARS-CoV-2 and COVID, first of all, we have a virus that has a great degree of variability. We know that from the variants. Two, the immunity, either from infection or from vaccine, wanes over time, and we don't have a wide acceptance of vaccination. So I believe that we're not going to be able to eliminate it. It will hopefully get down to a low enough level where it does not disrupt society, doesn't disrupt the economy, doesn't disrupt our social interactions.
Potentially it could, right, Doctor? Because you also
and
said
I do hope, and I believe we can do that, particularly if we get more people vaccinated, to get it at a low enough level where it doesn't disrupt us. That's what I was trying to say, where I don't think we're ever going to get rid of it.
But I was asking you about this herd immunity thing, of which you seem to have your doubts that it might not apply to COVID. If you're right, then it is a constant. It is back and a reminder with us indefinitely. This happens at a time when we're getting, again, disparate advice on how many shots you get, 1 dose, 2 doses, 3 doses, how they're spaced apart. What do you recommend?
You know, I don't think we can make a firm recommendation now because, again, Neil, it is a bit of a moving target. The one thing we do know that everyone really does need a third shot, a boost, if you have the 2 shots of an mRNA. The data on that are incontrovertible.
What if the antibodies don't hold as long as you thought, and all of a sudden now that's in question? And that applies to a lot of the vulnerable, for example, like myself. So I'm wondering then how that changes what you recommend. Obviously, different, pieces of advice for some patients versus others. But how do you, when people seek your medical advice on this, what do you tell them?
Well, what I tell them is that everybody, whether you have an underlying condition or not, whatever your age, if you're eligible to get vaccinated for that third boost, get that third boost for sure. The real question then is, what about a 4th dose? Who needs a 4th dose? And, the FDA and the CDC has gone along with this, have now made eligible for that 4th dose people who are 50 years old or older, and particularly people who are 65 and older, and definitely people who might have underlying conditions that make them more likely to get a severe outcome. So as a physician, if I'm in an office or in my clinic at the NIH, and someone comes in who's 52 years old, 53 years old, and might have hypertension or diabetes, I unequivocally would recommend that they get that 4th dose, without a doubt.
So, Doctor, in China, cases are still spiking for, I believe, this BA2 subvariant you referred to. It's enough to keep Shanghai all but shut down. Some people have been allowed out of their homes, but most not. And I'm just wondering their response to the spike in cases there, which indeed is a spike, but a fraction of what it was at the height. Do you fear some get overreactive and that lockdowns like that are overdoing it?
Well, no doubt, Neil. I mean, that is, I believe, counterproductive. If you are going to shut down, you shut down for the reason of giving you the opportunity to do things like vaccinating your population to protect them. You cannot shut down indefinitely for the virus. The virus will ultimately infiltrate society. And what the Chinese have done, which I think is not a good public health practice, is that they have not fully vaccinated their people, and the vaccine that they use is not a particularly effective vaccine. And they have a lot of vulnerable people, particularly the elderly, who have not been vaccinated. So to just shut down and think you're going to escape the virus without doing the important things to allow society to open up again, namely vaccinating people, making therapies available for the people who get infected, that's the only reason to do a temporary shutdown. But to think that you're going to shut down and keep the virus out indefinitely is really something that is just not feasible.
So your thoughts then on Mayor Eric Adams in New York, it seems to be hinting that the vaccine mandate for city workers will remain in effect. He is not going to take that back. What do you think of that?
You know, Neil, as I've always said, you leave those local decisions to the local authorities. I mean, there are broad, general public health principles that are applicable universally, but things are different on the ground at different locations. And that's why I and many of my colleagues have always been in favor of creating and articulating broad public health principles, but leaving the ultimate decision to the locals, because each locality, be it New York or Texas or any other place, Florida, Seattle, San Francisco, they're all different. They have differences that I think need to be taken into consideration when the local authorities make those decisions.
Doctor, finally, if I could weigh in on, politics. I know you eschew this subject, probably wisely, but Steve Moore, former top advisor to him, was just on our show saying he had had dinner with the former president a couple of nights ago, and he's fully convinced, that is Steve Moore, that the president is going to run again, and he's polling well against Joe Biden. In fact, depending on the poll, up by a couple of points to as much as 8 points. So if he were to become president again, would you stay in your current capacity or want to?
You know, Neil, my staying or not in my current capacity has absolutely nothing to do with who the president of the United States is. I'm a scientist, I'm a public health official, and I run an institute that has a major role in the development of countermeasures and doing the science against these types of emerging infections. That has never been dependent on who was in office in the presidency or who controlled the Congress. It's
but
completely separate.
It's fair to say, Doctor, it was a bit of a fractious. You were the public face of this, obviously, and as you have been in prior administrations as well. It would seem unlikely that you would be in a new Trump administration, or am I overstating?
I think you're overstating, because my position is not a political position, and decisions that I make about my job as a public health official and a scientist, you have to believe me, Neil, it has nothing to do with politics and who's in office and who's not in office. And any decisions about what I do will be completely independent of that, I promise you.
So just to be clear on this, you've worked with President Biden, you've worked with President Trump, you've worked with many presidents, but obviously prominently these two. Do you have a preference who you work with? Who makes your job easier? Who makes your job more helpful? Who is more conducive to the kind of things that you talk about?
You know, again, Neil, I think you said it in the beginning of your question. I stay out of politics, and you're asking me a completely political question, and I'm not going to answer that.
Okay, so you have President Trump in a boat and President Biden in a boat. I'm kidding. Dr. Anthony Fauci, very, very good seeing you again. Thank you very, very much.
Yeah, thank you, Neil. It's always good to be with you.